All right, we have two wonderful speakers, Ali and the wonderful Dr. Darren Berger. Dr. Ali Kirby is a private practitioner in this area, so there's a lot of atopic dermatitis going on here in this beautiful climate. And then Darren is in another part of the country. Anybody from Iowa here? Oh my God, you're the only one. Oh, sorry, I'm not allowed to laugh. And they're going to talk about the therapy of atopic dermatitis. And here they are.
All right, as Yola already said, I'm Dr. Darren Berger, and sadly I may be the only one that wants to admit I'm from the state of Iowa.
And I'm Ali. I'm born and raised in LA, which is very rare, if anyone knows. So.
And we're going to talk to you a little bit about how we address the treatment options that are out there for addressing atopic dermatitis.
So one of the biggest things that we have to concentrate on is client education. If you don't tell them what you need to do and they are on board with everything, it's going to be a really difficult situation for essentially the rest of that dog's life. So one of the things that needs to be brought up pretty much at the first exam is money, because this is not going to be a single exam. You're going to be seeing these patients over and over again. Also having them understand that multiple allergies exist. A dog cannot just be atopic, can also be food allergic, can be flea allergic, and unless you address all three of them, they might not feel more comfortable. I cannot cure, neither can Darren, an atopic dog. I wish I could. I probably wouldn't be here today. I'd be off on an island somewhere, but you can't cure that dog, so it's a management strategy. Quality of life is going to be the most important. Our goal is to make that dog less infected and less pruritic over the long term. And you have to be empathetic with these clients. It's very frustrating, not only for you, but for them and for their pet to be dealing with these diseases that are so chronic. And unfortunately, I lost my fairy wand when I was 4 years old, so I do not have a single cheap, safe, effective drug for all patients. So they need to know that some of this is going to be trial therapies to see if their dog responds. One of the first things that we often start with is antihistamines. Keeping in mind, these are not meant for those 10 out of 10 allergic, itchy dogs. They're going to be made more for preventative use rather than acute flares. So we use them quite often in private practice, but you have to know that going in, that you're not going to get the response that you want if you're using them on those severely allergic patients.
And we kind of think of them very similarly in that antihistamines are really targeting histamine release from mast cells. And as we know now, the mast cell is not the key cell involved with atopic dermatitis. We're dealing with lymphocytes and histiocytic cells, which is where a lot of the new medications have gone. So we think of these more as preventative, but more so from drug-sparing. They're drug-sparing effects of things that we'll talk about here a little bit later. And that kind of brings us more along the line of this supportive care, is that fatty acids. And for a long time, we've used fatty acids. And what are the reasons we use them? We think about them in terms of they may alter the arachidonic acid cascade, so decrease some inflammatory pathways. They may decrease leukocyte activation. Our hope is that they will improve the barrier dysfunction that we now know is a big problem with atopic patients. And so we look at it that way, and something that came out of the key thought leader discussions about a year ago was, well, what's that target dose? What are we looking for? And something that came out to be a little bit unanimous was we're kind of looking for at least 180 milligrams per 10 pounds of body weight with the research that is out there. And thankfully, those at Hills provided us with some information in terms of where are some of these diets at and what are they targeting. But again, we look at fatty acids as a drug-sparing therapy, not a sole therapy for our moderate to severe atopic patients.
And kind of the same thing in private practice. This is going to be more of a supportive care. Once you rule out food allergies as being a factor in that animal, if they ask you what diets you should be recommending, you should be thinking about the diets that have that increased fatty acid, because it'll also decrease what they're paying per month, so they don't have to give additional capsules or different additional liquids. They could just feed one of these diets that are already enhanced with those EPAs.
So that brings us kind of to our first question, kind of making sure that we're getting across our big high points here. And that first question is, how do fatty acids aid in the treatment of atopy? Hopefully go on to the next slide here.
Yes, it's supposed to be the answer percentages, I thought, but there we go.
Oh, we're getting there. And so Thankfully, yes, we're getting there. This is really our goal here is we're wanting to decrease the other drugs that we're going to get onto here in a minute.
Oh, it just went down. I think they're upset with my excitement.
So we'll get back here to...
So topical therapy is utmost importance. It's also one of those things that has supportive care. Ideally, there's lots of shampoos out there. There's now mousses, there's sprays, there's pads. Any time that you can decrease the amount of pollens that are getting absorbed through the skin, the better. It also rehydrates the skin, allows for topical administration of certain medications, makes that animal smell better. There's a lot of practices that the bathing can have for you in trying to decrease that overall medication load of that patient.
And again, we look at it as supportive care, and we recommend many of our atopic patients, they should be bathed weekly to every other week. The key thing out there, you can overbathe dogs. That's really not a dermatologist perspective. We think the more bathing, the better. So we're looking for that weekly to every other week basis to kind of keep and help lower some of these other drugs that we're going to move on to here. And that kind of brings us to where we are now, which is more the disease-specific drugs. We've talked a little bit about supportive care. It's nice because it's safe, it's cheap, we're not going to do any harm, but for the most part, for many dogs out there, these last three options just aren't going to be enough to make a big difference in their overall disease severity. So one of the hallmarks, and shown here is Zoetis' itch cycle, is an interplay between the skin, the immune system, and the nervous system. But the hallmark of veterinary dermatology for a long time has been glucocorticoids. And glucocorticoids are beneficial, as you can see from many of the buttons up on the picture, is they're interfering with just about every aspect of the itch cycle. And along those lines, this is that option where I look at owners and say, I know that if we use this option, we can make your patient better, but it's not always the best option to choose. So what do we look for? We look for steroids in those dogs with super short seasons, where we want something that's going to be very quick acting. For those dogs that have flared up, they're having a really bad day and we need to get them back under control. And those patients where we've talked about every other option under the sun, and this is what they're elected, or in those patients that are financially constrained, because steroids are cheap, that really want to do what they can for their dog, even though their financial limitations may keep them from doing some of the other options.
And we use it very similarly in private practice. I kind of tell all my clients it has a very, very general mechanism of action. Pretty much the steroid receptor is on almost every cell, so you're going to get a lot of unintended consequences. So when I ask you, well, what side effects my animal can have, unfortunately, they've written books about this in human medicine. So to go over all those side effects is going to be time limiting. So really touching on that they know that there's side effects that are just more things that need to consider for long-term use. So this is actually PJ. PJ came in to me very much like an armadillo. He was on steroids for atopic dermatitis for around 3 to 4 months. And he wasn't at pretty high doses. He was at pretty anti-inflammatory doses, and he came in with a pretty severe case of calcinosis cutis. There's a huge individual tolerability difference. So what that dose that may be safe may not be safe for all patients. So keeping that in mind. And then I got a very nice present from PJ's owner about 8 months into therapy, and I kind of had a little freak attack moment from vet school, like, I haven't looked at an x-ray in 10 years, what is this? And this is actually the calcium deposits going along all the ridge of his back. I've now seen this dog for 5 years, and a lot of that is still present, despite not being on steroids for quite a long time. So some of these side effects are definitely long-lasting.
And we think about the side effects from the academic side as well, too, in terms of that we go through a laundry list of talking about the things we know can happen. And one of the battles we fight is the societal stigma. Many people are aware of steroids. They think of things. Sadly, many people are worried their dog's going to turn into Arnold Schwarzenegger. And I sadly have to disappoint them by saying, no, they're more apt to become bald and pudgy, kind of like me. So the bearer of bad news in many of those instances. So that kind of brings us on to the next kind of, or really the first FDA-approved treatment that we had for atopic dermatitis, which was that of cyclosporin, brand name product of Atopica. And one of the big advantages was, all right, we have a potentially safer option. We're interfering with fewer spots on the itch cycle. The way that we think about Atopica is that, okay, we have a safer option, not going to necessarily work in everyone, but does work in a big chunk. A better option because of how it's onset of action is going to be delayed anywhere from 3 to 6 weeks. What we look at and what we think of is, okay, longer-term therapy, those patients with more non-seasonal symptoms or longer seasons of symptoms, those dogs who have a lot of inflammation, because we're still inhibiting kind of the whole lymphocyte workup. So those dogs with recurrent pyoderma or allergic otitis are really where we're looking at using this drug from our standpoint.
Yeah. So on our itch cycle, we went from 7 little buttons to 5. So that's always nice. We get less unintended side effects. I usually use this medication if I'm waiting for other therapies to come on board, specifically allergy immunotherapy, which I know can take 6 to 12, sometimes 18 months in some of our patients to come on board. I usually will always pair it with a steroid because I know the steroid is going to work a lot faster, give a lot more immediate relief. And then I have this as more of my long-term or mediate to long-term option while waiting for those allergy shots to come on board. And also if I have dogs that have other disease processes that I know could benefit from atopica/cyclosporin, whether that's perianal fistulas, sterile paniculitis, etc. So one of the biggest drawbacks to atopica is that anywhere from 4 out of 10 to 3 out of 10 patients will have some GI upset, whether that's vomiting, decreased appetite, diarrhea, things like that. A lot of it can be minimized after that first week to 2 weeks of administration, but there's a subset of patients, no matter what you do, can't tolerate it. So a couple of my tricks is I give it with food, give it without food. We pre-medicate with Pepcid. We also freeze the capsules, and I've been doing that for a long, long time. I got that from one of my mentors, but there was recently a study published that shows that there's no change in bioavailability if you freeze the capsules, so you still get that clinical effect, but also get a decrease in the amount of GI upset.
So the other fun things that we like to talk about, because we are still messing with the immune system, are some of the other things that can go wrong, and some of the things we can't always necessarily explain. So things like hypertrichosis, something that I would surely benefit from on occasions. And then also other infectious diseases. The picture on your guys' right is that of a viral papilloma that started shortly after therapy in the interdigital space, and then resolution following discontinuation of this therapy. So we still have unintended consequences that we run into a lot of times with this form of therapy.
So gingival hyperplasia is also one of those side effects that we see with atopica use. It also happens in humans as well. Generally in my patients it happens anywhere from about 5 to 6 months into the medication and sometimes longer. As you can see, it'd be quite dramatic. That canine is almost completely covered by the growth. Now a lot of times this can be minimized if they're doing toothbrush techniques, sometimes with azithromycin, if you cut back the dose, if you stop it altogether. I've had a lot of patients actually all that tissue go away with time after stopping the medication, but it's something to always monitor when these dogs are on therapy, what's going on with their gums.
And we think of this kind of side effect as well too, as the more medications we're adding in with cyclosporin, the more likely these type of side effects are to occur. And in addition, adding drugs that may interfere with the metabolism of cyclosporin, things like ketoconazole or other inhibitors of the cytochrome P450 system in the liver, are going to potentially exacerbate or bring on more of these adverse events that we run into.
So now we're moving on to Apoquel, and we went from 7 to 5 to 2 little buttons, so even more specific for our itchy dogs, so less unintended side effects. The nice thing about this medication, it does work very, very fast, so that's always a key when you're trying to get rid of that itch factor in that 10 out of 10 dogs, so it works at the same onset as steroids. It is working as a JAK-STAT inhibitor, mainly JAK-STAT1, but the main action for us is that it's actually inhibiting interleukin 31.
And so along those lines, we're now starting to get much more specific in terms of what our target is, but we're still inhibiting the receptor for IL-31. So we still have other, as we all know about immunology, if we think all the way back to our veterinary school days, is that if the immune system is anything, it's redundant. Things always have a backup to the backup, or they also have more than one kind of role in the body. And so we still do get some other unintended consequences, or we do inhibit other interleukins such as IL-4, 6, and 13, other interleukins that are involved with the pathogenesis of atopic dermatitis. So we're not only helping the itch, but we're also a medication that allows us to manage atopic patients. And so the way we think about using this drug is it doesn't work in everyone. It's not the silver bullet that everyone hoped. You know, one of the best things that probably ever happened to Zoetis was the drug went on back order the moment it came out. So it was kind of, oh, we got this new miracle drug that's going to cure everyone. But as we alluded to, there's no silver bullet. There's no one option. But it gives us another tool. So we think of this in those just kind of really pruritic dogs that may be manifesting more with recurrent pyoderma, but we're looking at this as a long-term potential treatment option in a certain subset of patients. It's an option, and we talk about that with the owners.
So these are just some patients kind of pre and post Apoquel. The one on your guys' left is my own personal dog. Actually right is on my own personal dog. That's Isabella. She was polypharmaceutically challenged for quite many years, over 10. And then this was 6 weeks before Apoquel and then 6 weeks after. And then Olive is the patient on your guys' left. That was actually patients of Darren. So I'm sure he'll explain.
This is one of my train wrecks. Olive, who was also polypharmaceutically challenged, as Ali would like to say, had failed multiple diet trials, home-cooked diet trials, Atopica and steroids, immunotherapy, and all options. And at the point, after about 2 years of steroids, I had made her sadly iatrogenically Cushingoid, but we were going for comfort with this patient, maybe shortening her quality of life. But after Apoquel was released, we were able to get her transitioned, and the bottom picture is that of Olive about 3 to 4 months after initial therapy and getting her weaned off of steroids. So it's a nice tool, but it's not the only tool. And as with any drug, we have unintended consequences. We have other potential side effects out there. We've talked a little bit about them, but that of vomiting and diarrhea, it's less than we see with Atopica, but it's more some of the things we don't know. And a lot of the data to this date, long-term data, is on a very small subset of the population. And we have concerns in terms of things like reactivation of demodicosis. Some of us out in practice are seeing some of these dogs come in who may not have had Demodex when they started the medication, but we're seeing it after. But the more concerning thing for us is the potential, and I highlight that word, the potential, because we really don't know yet, is that of malignant transformation or development of tumors. And the kind of tumors that bother us, or the potential, is that of round cell tumors. And this is one of my patients, a little Scotty who developed a 5-year-old Scotty who developed a histiocytoma about 45 days after starting the medication. But we wonder about these things. We don't know. But with time, just like with Atopica, we learned a lot after its release, and we're still seeing new side effects being described even to this day, 15 years after its release.
Yeah. And we have to remember that Apoquel is not a diagnostic tool. It is a treatment. So there's going to be a lot of patients it does not work in. This patient had been pruritic for months and months and months despite Apoquel therapy. And what that dog actually had was scabies. So you're not going to treat all pruritic dogs with Apoquel or any medication. You still have to do your diagnostic workup and make sure that you eliminate everything before you potentially lose long-term medications.
And clearly we required a happy hat in this patient. We weren't so happy about being itchy for 4 months. So, but again, as Ali said, sadly, people are starting to use some of these new drugs as diagnostic tools rather than going through the workup and identifying clinical signs, as Doug talked about, and then doing the diagnostics needed, as Christina alluded to. That brings us kind of to the new and final kind of implementation in terms of pharmaceutical interventions, and that's the new USDA conditionally licensed product that we're all referring to as CADI, Canine Atopic Dermatitis Immunotherapeutic. What's cool about this is, as we've talked about the entire morning, is that we're going from lots of buttons to fewer and fewer buttons. So we're getting super, super specific on our target. And what CADI is it's a canonized anti-IL-31 monoclonal antibody. So rather than messing with the receptor, we're now binding up the interleukin before it ever gets to the receptor. And we have found this to be a potential option, or one of the big options we see for this is that there's no age restriction, where Atopica has a 6-month age restriction and Apoquel has that of a year age restriction. This therapeutic option can be used in any age of patient and patients on any medication, so we're not getting the interference with the other medications that we have seen in the past.
And also nice if there's other comorbidities that patient has. If you're dealing with an animal that's also diabetic, that also has other numerous diseases, this can be used at this point at least safely. It is a subcutaneous injection, generally lasts around 3 to 4 weeks, but it's not allowed to be administered or not recommended to be administered more than every 30 days. It is a refrigerated product, and right now it's on conditional release, so we don't know the exact release date. The main side effects that we've seen is that obviously it's not going to work in all patients, so you definitely need to pick and choose your patients that you use it on. And then they have seen some GI side effects as well in a subset of the population.
And so some of the data that we have, at least now, and I apologize, this slide might be just a little hard to see, but what's really coming out is we've talked about all these medications, the side effects go down and down and down, but what we're seeing with the immunotherapeutic is maybe a little GI upset, maybe a little injection site irritation, but for the most part, the side effects being seen in trials are not exceeding that of what you would giving the placebo product. So that's really one of the exciting outlooks that we see for entering what's now known as the biotherapeutic age, this idea of using natural compounds in the body to kind of reverse the effects of some of these diseases. So that kind of brings us to our next point, that of, what is our target when we talk about Apoquel and that of Caddy? What is our primary target cytokine that we're going after? Let's see.
Polling open.
We're
80%. That's pretty
80%.
good.
We're hitting
Right
some
in
of the things. So that IL-31 really is the target, both for the monoclonal antibody Caddy and that of Apoquel. We're messing with the receptor in the case of Apoquel, and we're binding up that interleukin-31 before it ever gets to the receptor in the case of Caddy.
So this is a little shout out to Doug DeBoer, who recently had a paper published on sublingual immunotherapy. So one of the main things that we like to do in dermatology, both in private practice and university, and then also out in your guys' clinic settings, is allergy testing and immunotherapy is going to be your safest, cheapest long-term medication for that patient, whether it's the standard injection route subcutaneously or with the more newer forms of therapy in terms of oral immunotherapy. What's nice about this is it now gives an option for those clients that are scared of injections. They live a lifestyle where they travel a lot, so it's not ideal to teach all these different people how to inject things. So it's really definitely revolutionized a part of our treatment modality for a subset of the population we weren't ever able to address before.
And we think about this now with the addition of sublingual immunotherapy to that of the subcutaneous injections as another option. It gives us a way of, if we figure we get owner buy-in, that we're going to increase our compliance. And if we increase our compliance, the odds of seeing a successful outcome in a patient who goes through immunotherapy, that's what the whole goal was in the beginning. But we agree kind of this really is the safest and cheapest option. Now, the upfront cost may be a little bit more steep than some of the others, but we're not looking at the long-term monitoring. We don't have patients coming in every 6 months for blood work or reevaluation. We're not worried about side effects later on in life that may increase the cost of treating that patient. So this is really one of those interventions that we feel is safe for any patient. Diabetic patients, Cushingoid patients, we agree a lot on private practice and academia that way. But age, really not a contraindication in terms of our standing. But the earlier we can start, really the better chance we have for a successful outcome.
And in our practices here, we definitely rely, just like Dr. Restrepo had said, on intradermal testing, not for the diagnosis of atopic dermatitis, but for the treatment of it. So when we're doing these tests, we have already ruled out the other allergic disease processes, and we're strictly looking for what we're going to put in that immunotherapy vial, whether it's sublingual or whether it's an injectable paste product. And then we're allowed to actually do up as many antigens as that facility wants. So sometimes you are limited with your blood allergy testing exactly what you can test for. You can specify your panel to your region and be a lot more direct about what you're going to be using.
And we look at it the same way, although we still prefer intradermal testing. When you look at studies, the outcome measure, if you blood tested or if you did intradermal testing, there's really not an outcome measure. But sadly, what those studies don't look at is the individual who's behind making those decisions and that type of thing, which may be even more important than just what test you choose. But we also prefer the intradermal test from the standpoint we can test more antigens for the same cost. Most dermatologists that I'm aware of are somewhere between 55 to 70 different allergens that they're looking at, where the blood tests are around 35. So those are the kinds of advantages we look at for it, and we maybe get a little bit more information from our standpoint, the way we think about it too, where the blood test is maybe measuring the presence of IgE in the bloodstream. We think of intradermal testing as not only measuring the presence of that IgE is present, but it's actually being bound up by the mast cells out in the dermis as a way of detecting cross-linking during the testing. So just because we get positive tests and we have all this information, what do we do with it, or how do we think about it? And the way that we think about it is a little bit, I think, differently than the way it's conveyed to the general population. we've got the testing results, and not all allergens are created equal. We start talking about different trees and what trees pollinate longer and how allergenic is their pollen, and we kind of get geeked out a little bit on a dermatologist standpoint when we start talking about all of this. But we're looking at potential cross reactions, and we're looking at season, and we're looking at environment, and really going through detailed history with the owners to try and create the most effective, if you want to call it a vaccine or immunotherapy possible for that patient, and trying to make changes based on what we're seeing. And Ellie's seen some unique things here in Southern California with change in season as well, too.
Well, in Southern California, we don't really have much of a season, so it's one of those things you have to take everything into consideration when you're building that vial, because you have to think that this is a medication that animal may be on for 10, 12, 15 years. So if you have a history where those dogs are primarily flaring during the winter months, but you have no other reason, but they're allergic to certain things like pine trees, you may want to ask what they bring in at Christmas time. That may help you out. But definitely looking at cross-reactivities is going to be the biggest thing. When you get your results, you should spend the most amount of time actually picking those allergens, because that is going to be your bread and butter, whether or not your patient potentially has a success or a failure by looking at your patient history, the seasonality that they're affected, what they became allergic to, and then also what those cross-reactivities are.
And so that kind of brings us to our last question that we had for you today, which is which treatment options work less than in 24 hours to reduce pruritus in our patients with atopic dermatitis? Our options are steroids, Apoquel, Atopica, or both steroids and Apoquel. So.
See where people end. Let's hit the 100%.
So we got the right, we had no one going for Atopica at least. So that really, when we look at this, there was kind of the thought when Apoquel hit the market was that it's going to work faster than steroids. And what a group out of Australia really showed was that within that first 24-hour period, there really is no difference. But when it comes to speed of onset, we're really left with that of steroids and Apoquel when we try to stop pruritus as quickly as possible.
And then we have long-term goals for our patients, and definitely one of the long-term goals is not only to decrease pruritus, but decrease infection load. The less you can use in terms of antibiotics and antifungal is going to be the better for that patient and for us long-term. And having that happy client is probably going to be up there on that list as well.
And from our standpoint, setting, as we talked about at the beginning, setting realistic long-term goals. And sometimes that's really seeing the owner down and being honest with them and what really are the goals. Although we'd like to make every patient itch-free, and I can pump enough steroids into every dog to probably make them itch-free, that's not necessarily the best thing for that patient. And realizing what's the difference between a comfy dog and an out-of-control dog takes a lot of interaction with your owners. But through owner interaction and realistic discussions, hopefully we can achieve a better long-term outcome for a lot of these patients, especially as we start to get a lot of these newer options. So, thank you.
Thank you.